5 seconds. 5, 4, 3, 2, 1.
Just a minute, sir has.
We are live now. Now we can.
Yeah. Good evening, everyone. Yeah, sir has joined. Yeah, welcome to the platform of Orthopedic Research and Education Foundation, India. Over to John, sir, to please introduce the.
Are we live?
Yes, sir. We are live now.
Are we live yet?
Yes, sir.
Okay, so good evening, everybody. Welcome to today's webinar brought to you by the Orthopedic Research and Education Foundation. And today we have Dr. Ritabh Mittal from Spinal Injury Hospital, Delhi, who's going to talk to us about biofilms. As you're aware, biofilms was something which we almost didn't know of about till maybe 20 years ago. And then gradually we learn about its importance, especially in chronic infections involving the bone, where organisms secrete this fluid or this membrane which protects them from antibiotics and the host's defenses. So we have Dr. Ritabh Mittal talking to us about this today. So over to you, Ritabh. Ritabh?
Please unmute, sir.
Thank you. Sorry, it's always an honor. And John, sir, thank you for giving me this opportunity, and Janki for working behind the scenes tirelessly. So, biofilms, I'll first give a brief introduction onto what the microbiological environment is like. So it's like a theater. It's like the Mandi Bazaar of, you can say, a busy marketplace in Delhi, Patna, anywhere in India. So the bacteria also are a mixed variety of commensals who are not bothered with anything, anybody else, symbiotic who are looking for opportunities and cling on to something, and pathogenic who are fundamentally pathological and they will infect anything that they get in touch with. So microbiome basically is a theater of microorganisms. Now, these could be bacteria, fungi, algae in the real world. But what we are fundamentally interested in is basically the bacteria. So what happens when the skin breaks? There is a change in the environment locally. So harmless bacteria present on the skin have an opportunity to now alter the behavior. It's like someone getting exposed to or finding a 100-rupee note on the road. So an inherent greed comes to the mind. So should I leave it alone or should I pick it up? So similarly, the bacteria, when exposed to the fluids in under the skin, have an opportunity to alter their behavior. And bacteria that can form biofilms survive the best in such environments. So biofilm formation by default is the natural mode of bacterial existence anywhere in the world. We will come to an example. The importance of the biofilm is that it helps the bacteria form a colony of their own. It protects them from the host immunity, as Dr. John Sir said. And the ultimate aim of the biofilm is not to overwhelm the host. They want to coexist with the host. If they overwhelm the host, they too will go along with the host. So the most common bugs encountered in orthopedics, wherever there is an infection and an implant, are most commonly Staph aureus, Staph epidermidis, and Pseudomonas aeruginosa. So these three bacteria are very, very robust in forming biofilms. So these are the 8 concepts of biofilm, and I'll take you through each one of them. The first one is adhesion. So you would have seen a picture like this as on the screen of algae forming under rocks. So these basically are examples of adherence. The algae, the bacteria that are flowing in the water will keep flowing and get washed away into the sea and the river. But those bacteria that can stick somewhere can survive. So the natural environment is actually very competitive, and so it is inside our human body. And those bacteria that can stick survive. The most essential ingredient for sticking is sugar. So if you have eaten something which has protein in it and it spills on the floor, or some fat, oil spills on the floor, or something sugary, you will find that the sugary thing is the most sticky. Oil you will tend to skid and fall, and protein is more or less harmless that way. So bacteria that can secrete sugar molecules, what we call polysaccharides or glycocalyx, are the ones that can survive best in a hostile environment. So what is this glycocalyx? So glycocalyx is, as you can see on the screen, that there is a bacterial surface, and this is the bacteria cell wall below. So glycocalyx are basically these chain-like strands, which are sugar molecules, which help the bacteria attach onto a surface. So these are the glycocalyx fibers. So once these fibers attach to the surface, what is their clinical relevance? Any bacteria which can throw a glycocalyx or sugary molecule can attach. So invariably, most of the infections to begin with are polymicrobial. A host of bacteria, gram-positive, gram-negative, can attach onto a surface. Staph aureus, being the most aggressive, is generally the most common. Staph epidermidis has a lower potential to throw out glycocalyx, but in the presence of hardware, it becomes robust. And bacteria stick on better on stainless steel surfaces. Hence, there was a trend towards more of use of titanium to reduce the risk of infection. This is just one aspect of many. So once the bacteria stick to the surface, they then secrete something around them to cordon off their area. Like we built fences around our homes, the bacteria too cordon off themselves. It forms a protective boundary and insulates the bacteria from the host immunity. The nutrients, whatever are present, are retained, and the bacteria then now have a safer environment to multiply and mature. So once they start multiplying and maturing, then there is a phenotypic variation in the individual bacterial species. So on the surface, we have rapidly multiplying bacteria, which are more sensitive to the antibiotics. But as we go deeper into the biofilm, the cells are maturing and they are less sensitive to the antibiotics. Once the bacteria have started multiplying and maturing, they communicate with each other. This communication has been given the term quorum sensing. So the bacteria generate a single molecule. That molecule can detect a change in the signal molecule levels, and they respond and regulate. So basically, this is a DNA RNA mechanism. So gram-positive bacteria have a different mechanism. Gram-negative bacteria have a different mechanism. Fundamentally, it is at the DNA RNA level. A signal molecule is generated and the bacteria respond accordingly. The other natural phenomena that happens is as the bacterial film forms and the bacteria start utilizing their nutrients, the nutritional supplements available for the bacteria start depleting. So the more rapidly multiplying bacteria on the surface need more nutrition, and the grandfathers below need less food to survive. So there is a depletion in the supplements as well as an oxygen gradient which depletes as we go deeper into the biofilm. And this multiplies the antibiotic resistance almost by 1,000 times. So the children playing on the surface may be more resistant to getting kidnapped and attacked by the antibiotic, but the grandparents and their parents sitting underneath at the bottom of the biofilm attached close to the surface are resistant to all forms of antibiotic. So coming to the antibiotic resistance, one, at the surface, the antibiotic may be able to penetrate up to a certain depth. But beyond that, the microenvironment gets altered. And there, the grandparents, you have the persisters. So as the antibiotic penetration also lowers, the bacteria are multiplying slowly. So the resistance is phenomenal. So giving antibiotics is in themselves not a solution in any form of infection related to orthopedics. So once the bacteria have matured, formed their colony well, they intermittently disperse some of their family members into the blood pool. So these are the bacteria which are picked up by the blood cultures. So they are planktonic, free-floating bacteria, and they do not give an indication as to what are the actual bacteria, what is the actual bacterial phenotype species present in the biofilm, driving the chronicity of the infection. So, as soon as a biofilm has formed on the implant, most likely the biofilm has many bacteria in it with predominance of one. All the bacteria there are extremely resistant to antibiotics. Those that are shed off intermittently are picked up in the bloodstream. So the bottom line is giving antibiotics is not going to help. And unless the biofilm is out, the infection is going to persist. And unless the implant is out, the infection cannot be eradicated. So a biofilm basically suggests persistence of infection. And mostly the biofilms form on dead soft tissue, dead bone, and implant. So I'll take you through a simple case. This is a 15-year-old boy who had a fall from height. He had head injury and an open shaft fracture, femur. So OREF with plating was done. 6 weeks later, there was pus discharge from the surgical wound. So the question is what to do. There was a sinus, as you can see, and there was active pus discharge. Remove the plate, debride the bone, put an X-fix as temporizing measure. Remove the plate, debride the bone, put a plaster as a temporizing measure. Remove the plate, debride the bone, and go ahead and do a nailing, or wait and watch. This is 6 weeks. So what I did was wait and watch. Now, wait and watch, what should be done? Should we give antibiotics to prevent the subsequent sepsis or bacteremia? Should we put the patient on bed rest? Or do we do an ESR CRP regularly? Or take X-rays every 6-8 weeks to see healing? What I did was, the child did not look very sick. He had bearable pain. He was weight-bearing, walking with a walker. I suggested a healthy diet, no antibiotics, and a follow-up every 8 weeks. This is the X-ray at 20 weeks. I advise the parents to watch out for red flags, that is increasing pain, loss of function in the limb, or fever. Increasing pain suggests that there is some collection internally. Loss of function suggesting that the implant probably is not doing its job. And fever again suggesting that something is possibly not right. So this is 1 year later. I felt when the bone has reasonably united, we got him to the OT, and this is the intra-op image. As you can see a layer of bone. You can see the bone, and you can see a layer of tissue over the bone. So that bone was actually dead bone. It just came off. So there was a piece of dead bone with no attached soft tissue that had been pressed under the plate to maintain a good looking X-ray, but in effect, it was not doing its job possibly. It was dead bone. It had not contributed to healing, but possibly was responsible for the persistence of infection. So this is the biofilm on removal of the dead bone. So there was a biofilm under the dead bone. The entire bone is covered with biofilm. And this is what it looks like after the biofilm has been cleared, the plate has been removed, and all the screw holes have been curated and cleaned. So this is the X-ray after implant removal. As you can see the staples there. And this is him. This is the X-ray 1 year later. The fracture is healing, further healing. So this is the functional outcome of the child. He had head injury and he had a mild degree of spasticity. So this is 1 year after the index surgery of implant removal. That is almost 2 years after his first surgery. So for any patient with fracture-related infection, there are two treatment strategies. One strategy is if the patient is not very sick and the implant is doing its job, you can try for a union first. Let the fracture unite and then think of implant removal. The other strategy is that if the infection is overwhelming, eliminate it first and then think of bony union. So both options are equally effective. It depends from patient to patient and your experience and your judgment call. No one track is uniformly predictable in its treatment. I opted for the union first strategy in this given patient because of his general health being good, the implant doing its job, and it did its job for a year and the bone was given enough time to unite. Yes, in cases of infection, it may take the bone a little longer to unite, but bone does unite if stability is maintained. He was not on any antibiotic for 1 year. So the principles of treatment remain the same. If the implant is stable, if the bone is stable and the soft tissue cover is adequate, you can focus on nutrition and only talking. Give antibiotics very cautiously. If ever to be given, always give a combination of two, never a single. If you are going for the infection elimination first strategy, then the quality of the debridement is fundamental. So the take-home message for the audience would be that every case is unique in itself, and whatever happens, infection is devastating. The diagnosis is not the challenge. Elimination, eradication of infection is possible in the acute phases, but again, it should not always be the primary goal. If ever you have to do a debridement, radical debridement is critical. That comes from experience. Antibiotics at their best are not curative with any implant in situ. They are only a supplement to suppress the infection. And bone union and functional outcome, good functional outcome is achievable if we just stick to the principles. Thank you.
Thank you very much, Ritabh. As usual, putting things very simply and making it a very basic talk on a complicated subject. So I think as you've done a great job there.
Thank you,
I'm
sir.
sure there should be questions. One of the things which, I mean, I congratulate you on not giving him any antibiotics at that stage, because I think most of us would probably give him antibiotics for a short time and watch. I mean, so if you have obviously a discharge, because even though you have a biofilm and the bacteria are within that biofilm, every now and then, as you said, they throw off planktons. And just to make sure that these don't create further problems, I think personally, I would give him antibiotics for maybe 4 to 6 weeks, stop, watch things, and then see how things progress. So I would commend the fact that you've been able to do it without any antibiotics. But in reality, how many of us would do that is something which one really, and so you need to watch it very carefully, obviously.
Yes, sir.
Because any signs of fever, any signs of pain, you may have to give them antibiotics at least for some period to suppress the acute part of the infection.
He had been referred for implant removal by my seniors, by a prominent senior. I said, no, the implant is doing its job, and please stop all the antibiotics. Eat 2 eggs a day. If you are a non-veg, eat eggs. So watch out for the red flags. So he had come for implant removal, and every visit the parents wanted the implant out. So I could prolong it for 1 year.
Yeah, so yes, as you said, there are two strategies. If you think the fracture is going to heal and the implant is not loose, the screws are all holding, the implant is holding, giving it good stability, yes, you wait for the fracture to heal and then take out the implant and debride. And the other is where you have to go in, debride thoroughly, maybe even excise bone, and then opt for some kind of bone transport or masculate technique if you have a gap. Otherwise, you may think of something. I mean, like the options are, you need to debride, you need to stabilize, you need to manage dead space, and then you need to eventually get the fracture to heal. So I think those go hand in hand. But I think that case is done very well. But
I didn't do anything, sir. I only delayed. I was like a politician.
Yeah, but that's what I'm saying, that I'm not sure even in retrospect whether I would have done exactly the same way, but it's great that it's come out well.
I tell my colleagues, juniors, sometimes doing nothing is the hardest thing to do. So everyone wants to get something done, something to be done. Parents are aggressive. Parents want something to be done. So not doing something actually sometimes needs a lot of counseling and talking.
True, but it's not always the best thing also.
May not. So every case is unique. That's why I said, sir, I kept them on follow-up, and fortunately they stuck with me.
Sure. No, I think it's worked out very well. And I think in this case, your judgment was correct, but it's something which you need to watch from each case, from case to case. Yeah.
Yes.
Yeah. Questions from.
Yeah. Yes, sir. Sir, can you please this one share screen? If you can stop that one, that will be easier. Two questions. Concentration of antibiotic that affect biofilm.
Sorry?
So he has asked the first question, sub-inhibitory concentration of antibiotics. Means how much is optimal concentration of antibiotic or suboptimal? You want to ask that.
So who's asked that question?
So Subhanshu has asked, sir.
Okay.
Microbiologists generally give a report of MIC values and they write sensitive, resistant. So, yes,
this is the second one, sir.
But sir, sorry, sir.
Yeah, ask Subhanshu.
Sir, you said it is polymicrobial, sir.
Yes.
In microbiology report, it comes as a single organism.
Yes. Yes.
Predominantly, we can treat one organism, but how possible we are treating the other? Yes.
Yes. So for that, bache, the most important thing is not to give antibiotics before the surgery, and take tissue, not swabs or samples, take tissue from the depth of the wounds, from 2-3 different sites, send them for culture sensitivity. We assume infection could be gram-positive and negative. So we give 1 gram-positive, that is cefuroxime, and 1 gram-negative, like say gentamicin, for 3 days or 4 days. Once we have the culture report, we should grow that all the 3 samples should show the same bacteria. If we take 3 cultures. If one shows, say, Staph aureus and one shows Proteus mirabilis, then something is not right. There possibly could be a contamination. But if 2 show Staph aureus and 1 show Proteus, then probably Staph aureus is the predominant offending organism. So based on their culture sensitivity report, we give 2 antibiotics, never a single one, because bacteria can develop resistance to single antibiotics very rapidly. There we give antibiotic for at least 42 days then. So this patient post-operatively got antibiotic for 42 days, not pre-operatively.
Yeah, so I think this is where one has to be very clear about whether you're giving antibiotics prophylactically or therapeutically. And they're 2 different things altogether. When you give prophylactic antibiotics, I think the maximum you should give is 24 hours. And there's some people who would say just a single dose. And when you're giving therapeutic antibiotics, then you may have to continue it for 6 weeks or even longer. Today, I think the FRI, they have certain guidelines for fracture-related infections, and some of the antibiotic treatment can go on for even longer depending on the response, SED rates, CRP, etc.
Okay. So one more thing, sir. I have checked the question paper. In DNV, they have asked twice or thrice about biofilm in tubercular bacilli.
Yes.
So
tubercular bacteria also form biofilms. So it is not that they do not form biofilms, they also form biofilms. Then the question arises, how come we can give antibiotic, or how can we do implant-based surgery in tubercular patients? That is the fundamental concern or doubt. Spine may we put pedicle screws and give stability, and few doctors are doing giving ATT, and 6 weeks later doing a THR in a patient with diagnosed tuberculosis of the hip. So the antibiotics, the tubercular bacteria do form biofilms. The fundamental difference between normal bacteria and tubercular bacteria are that multiplies every 30 minutes. And Mycobacterium tuberculosis multiplies every 24 hours. Number 2, ATT achieves almost a 99.9% sterilizing role within the first 4 to 6 weeks. 4 drugs given together almost sterilize the lesion. Orthopedic mycobacterial lesions are anyway paucibacillary. Paucibacillary are slow multiplying, so they are never ever likely to become multi-drug resistant unless they were from the first go. So because they do form biofilms, that biofilm can attach onto surfaces. That biofilm does not form a lot of glycocalyx, so it's very weak in its attachment. When surgery is done, a radical debridement is done because, like say, let's say THR is being done. So essentially the infected tissue is being radically debrided, and cemented or uncemented hips are done. So you are essentially doing a fundamental debridement, removing the bacteria. You have almost given a what we call adjuvant chemotherapy before the surgery, and you continue it post-surgery. So these are the reasons why in tuberculosis, we can get away with implants placed in the affected sites.
Yeah, so I think today there's still controversy about whether you use implants even in long bones where there's infection. So the external fixator is not always the best solution for infection, especially in periarticular areas where the X-fix may not give you the best stability possible. And part of the treatment of infection, apart from what I mentioned about debridement, getting rid of any necrotic tissue, antibiotics, wound space, dead space management, is also stability of the fracture. Okay, and you need to find out the implant which gives you the best stability. And so for a shaft fracture, it may be a nail, it may be antibiotic impregnated. Similarly, in our practice for distal femur, proximal humerus, proximal femur, it's proximal humerus. I don't find fixators very good options for those situations, even sometimes distal humerus. So, or if I use a fixator, I'd use it for a very short time before I convert it to a definitive fixation.
So, one more thing, sir. There is when there is infection in TKR, usually we used to remove the tibial tray, that poly thing or the loose things. Is that anything related to this biofilm, sir, or?
No, so
I don't do TKR, THR, so that's a different ball game.
So a change of of the poly is basically for early infections. And the main reason you do it is because otherwise you can't get to the back of the knee where a lot of the infection may be harboring. So you need to remove the poly to really be able to debride adequately. Okay, and this is only for early infections where you want to retain the implant. Once it's late infection with loosening, etc., then changing the poly is of no use at all. Okay, you need to take the implant out, get it sorted out, and then do either 2-stage or a 1-stage revision, depending on your own philosophy and the kind of the type of infection, etc. Okay, so I think change of polys for early infections. First 6 weeks, at the most 2 months, where patient comes in early, you want to wash it out thoroughly, you want to debride adequately. And taking out the polys really gives you an opportunity to get to the back of the knee, which you can't get to with the poly still there. Okay. During debridement, as biofilm is sticky, whether we should use high pressure pulse lavage or not. That's a question from one of the...
Yes, sir. And one more question is there, sir. 2 questions are there just before. One by one.
I have never used high pressure. So in case I'm doing a debridement, let us say hypothetically, and we have to retain the implant. So we open the wound to its full depth and debride the tissues, clean the tissues with gauze, and we should see puncture, bleeding tissue from the soft tissue margins. And we hope and pray that we have done a good debridement, but we can't get under the plate, between the plate and the bone. So once we've got tissue, we know the antibiotic, the culture sensitivity, we can give an antibiotic. With an implant, the treatment plan is to suppress the infection, not to eradicate, suppress it till union. So I've never used a high pulsatile lavage system. It costs money. It costs money
So I think the high pressure pulsatile lavage systems have really gone out of vogue. Even the pulse lavage systems we have today are not really high pressure. So I think you can use lavage. It's but ideally you should be using, you need a lot of irrigation. And if you think the pulse lavage is the best way to deliver a lot of fluids in and wash it out, you can use it, but it's not something that you have to have with you. You can use irrigation in any other form.
Yeah, I think he's little confused. What we are using is low pressure pulse lavage. Usually the pressure is between 7 to 10 mmHg.
So it's not the pressure, it's how well you scrape the surfaces. So on soft tissues, we use a curette or a gauze piece wrapped around the finger. And on the implant, we use a surgical sponge and rub off the implant as much as we can. So that's where the biofilms adhere and attach. In AIMS, Delhi, I believe they do sonification of the implant, sir.
Yeah.
That's a further advanced technique to remove the biofilms and send them for culture sensitivity.
Sonification, yeah. So that's what sonification has used, not just in getting rid, but also in getting the cultures Even when you remove the implant, use sonification to try and get more yield from your cultures than you would otherwise. But I think there are ways of getting rid of biofilm to some extent. You can't, unless you remove the implant, you can't get rid of it completely. But at least on the surface of the implant, you can scrub it thoroughly and get it. But under the implant is difficult, as was mentioned. And in nails, it's a problem because you generally, in an infected nail, you need to remove the nail, do a thorough reaming of the medullary canal, and then put in an antibiotic nail or some other form of or whatever, antibiotic beads or whatever you think is necessary to keep the fracture stable, or an external fixator with some local antibiotics as well.
So
but you need, yeah.
One more question he has asked about biosurfactant used for prevention of biofilm formation. Is there the ways of prevention of biofilm formation?
The best way to prevent a biofilm formation, in my opinion, is to clean and drape well and do surgery well, not leave behind dead tissue, dead spaces. So all other chemicals and materials, antibiotics, spraying vancomycin on the wound like a tadka over the dal, these are all debatable techniques, but most important is how well you maintain your OT theater
I think
discipline, how well you drape the patient, how quickly or how efficiently you perform your surgical procedure.
So prevention of infection is the best way to prevent biofilm.
Yes.
Once it forms, then if you're cleaning it up, then the surfactants, basically soap is a surfactant. Okay, so
we only use saline in the wounds. We never pour anything else. No hydrogen peroxide, no other chemical, only saline.
So we
Nothing
use everything generously, from betadine to peroxide, because some of the infections we get are so bad. It's sometimes,
yes, sir.
Even if you are not. So there was a lot of studies earlier about these chemicals actually causing more damage to tissues, but subsequently they've started using betadine even in the West. Okay,
right.
So now they use it. They even use it in clean wounds at the end of surgery to wash it out, to prevent infection.
WHO recommends to wash the wounds with betadine.
Yeah, so I think now that thought of this, as long as you dilute it enough, I don't think it causes damage to the tissue. So
one bottle comes 100 ml, so we dilute it in a 500 ml, and then with a 50 cc syringe, we lavage the wound.
Lavage the wound, yeah. So I must say we do use it. I can't say we don't use it.
Just one thing, sir. May we call that induced membrane also a type of biofilm or vice versa? That
biofilm basically has bacteria in it, and the induced membrane has proteins that will encourage bone formation. So one has proteins and one has bacteria in it. If there is an infection in the induced membrane, that infection will eat away all the bone graft.
Exactly. And you don't get, and the biofilm is very different from the induced membrane. Biofilm is slime, like slime. Okay. Induced membrane is like a regular membrane, which you can actually suture back on at the end of it, if you have got a good induced membrane. So I think consistency wise, they are very different.
yes, I think.
Okay.
Yes,
interesting questions, interesting thoughts from the audience.
Okay, thank you very much, Ritabh. That was excellent.
Okay, sir, thank you.
And we hope to catch you again sometime. So till then, bye.
Pleasure, sir. Always a pleasure.
Always, sure. It's great. Thank you.
Thank you
very much, sir.
Thank you.
One more talk about polytrauma, sir has promised. But
okay, sure.
Polytrauma DVT, maybe DVT.
DVT also. Okay, sir. We'll do
right.
Okay. Controversial topic.
Yes.
Okay. Bye, Ritabh. Good.
Okay. Namaste, sir.
Thank you very much, sir.